so a lot of activity in cancer and Alzheimer's disease. That's sort of the virtuous cycle of the system working, right? There's not a lot of stat research going on now because there are such great stats that are available, and they're available in predominantly in generic form. It's like, okay, the system that moves on to what's going to provide new value to patients, because if it doesn't provide new value for patients in the marketplace, it's not going to be accepted.
So the reason I was asking is you said it's a large part unmet need, but was it also, was it the genomic sequencing that really triggered that, or was there other?
Oh, yeah. The advancement in understanding the genome and proteomics is leading to an extraordinary number of different research paths. And it's a combination of challenge and great promise. Like the greater the understanding of cancer is, the more the complexity becomes understood. But it's unlocking puzzles are incredibly complicated, but there's a terrific process to it.
I have two questions for Dr. Lay. One, there's sort of questions and comments at the same time. One is, what is being done in terms of training more physicians? I'm a graduate of the Medical College of Wisconsin, and there are 3 states that I know of. One is Texas, one is Wisconsin, and unfortunately I don't remember the third, that actually have programs to train more physicians. My own alma mater has a program where they're pairing with 2 underserved counties in Wisconsin, and they're fast-tracking the training of physicians. They're going to make it a 3-year program, so the physicians will come out with $150,000 in debt rather than $200,000 in debt, and then those physicians in return agree to stay in those counties and serve them. And what is New Jersey doing or planning or thinking of or considering that might increase the number of physicians needed here and keep them in the state? The second question has to do with basically the Medicaid fees being brought up to the level of Medicare fees, which is certainly an improvement. However, the Medicare fees themselves, if I had an entirely Medicare practice, I couldn't practice, because basically Medicare only pays me enough to pay for my office expenses. It doesn't pay my mortgage, my house, my kids' tuition. It just gives me barely enough to get by. And Medicaid, I dropped years ago because it paid so little, I couldn't possibly incorporate it into how I practice. So what is the state doing to improve on Medicare fees? And also, what is being done to take away the federal threat to, in fact, lower Medicare fees, that if it ever goes into effect, if the federal government ever actually carries out this year-to-year threat to decrease the fees, I don't see how many physicians can possibly continue to see Medicare patients under any honest. So if you just address those
just
two
remind me if I forget all those questions, I should have had it right in hand. But since it's a casual interaction, we can go back and forth. But one of the things to talk about in terms of higher education, that's a piece that a lot of the large institutions here in New Jersey are actually looking into fast-tracking medical education, so that instead of having the conventional 4 or 5 year program, we can actually trim it down to a 3-year program. And so some of the institutions I'm working with right now are actually looking at those collaborations and to make it more primary care centric, patient centric versus specialty driven. So those are some of the other things that we're actively doing. Now, under the Affordable Care Act, there are provisions by which the GME slots that are open are going to be reassigned and designated to primary care. So the goal is to really have this as a primary care physician-driven model. If you look at the accountable care organizations or some of the other bundled programs that we have in Medicare, through the Innovation Center in Medicare or through CMS, you'll see that a lot of the incentives that are built around the primary care model. So the goal is to really retain and keep the primary care and truly have them coordinate the care. The other thing that you're seeing simultaneously happening in the marketplace is boards, group here, where their health plans now paying for care coordination. So it's not just a pure fee-for-service transaction that's happening, but if there are offices and physicians and teams coming together, taking care of the 30% of the non-direct clinical care that is getting reimbursed. So those are some of the models that are evolving as we're looking at not just retaining physicians, but also nurturing them and grooming them to succeed as our health environment is changing. But also you're seeing all these collaborators come together and saying, okay, we want this to succeed, and this is how we're going to help them succeed. In terms of the fee schedules, that's an important piece. So we're moving from a utilization-based reimbursement model to an outcome-based, value-based outcomes reimbursement model. So the Accountable Care Organization, which was just a 7-page provision in the thousands of pages of the Affordable Care Act, has taken a life of its own now. And even though Medicare is pushing it, and an Accountable Care Organization is where physicians and with or without hospitals come together and take accountability to both the cost as well as the quality of the patient population that get attributed to them, they are taking a life of its own right now. So even though it is the law of the land to have that as a provision, it's the payers that are actually pushing it into a different horizon, and they're truly making sure that the program is capitalized.
If I can,
I don't know if I answered all of your questions, but if I did.
Yeah. Nobody can answer all of
But
them.
they were very good questions. And the Medicare fee schedule is really a federal program. And so Medicare, as we speak right now, is looking at changing the reimbursement model so that we're not dealing with the SGR fix every year, so that we're not dealing with the 3 times more that we pay in certain parts of the country with the outcome staying the same based on the Dartmouth Act.
on supply questions, I was surprised to learn that New Jersey has the highest percentage of foreign medical graduates in the country, they stay. And so, that's relevant because between 1980 and 2006, which was a time when the U.S. population grew by 1/3, the number of medical school graduates domestically didn't grow at all. And so you actually had a significant decline in the per capita number of doctors. And so if it worked for foreign medical school graduates, you would have had those going in. And with respect to the SGR, you just mentioned the cap, the legislative cap was never enacted on
But always a threat every year.
on Medicare fees for docs. The CBO recently reduced the cost of eliminating it from $246 billion, or a couple of years ago it was $300 billion. Now they're saying it's only $138 billion. The reason they are is because on MedPAC's advice, and under the ACA basically, they're holding the physician reimbursement rates pretty much to about the growth of the CPI. So people are getting it better, they're not getting it worse off. But so I think you're going to see some action on that. I don't know if there's going to be this big outpouring of new papers.
I don't know if you want to address this, but I'm particularly interested in the prevention side of this. And I know this has been a very comprehensive panel, and we address all the issues that come up. But if you can comment on the role of prevention on healthy diet and lifestyle and what that could do to address this problem, particularly the obesity epidemic in this country, because it seems to me that so many of these problems are now metabolically caused, and it's really been a power that we did with tobacco, maybe just address the problem of bad food and sedentary lifestyles.
So I'll take a stab at it, and then maybe you can, and maybe from a pharmaceutical perspective and a large employer. So prevention is key, right? I mean, that's one thing that we all know. Under the Affordable Care Act, all preventative care is covered at zero copay on the part of the patients or members. And so where the prevention debate is actually evolving as we speak is not just primary prevention, not just secondary prevention, but tertiary prevention. So from a public health perspective, primary prevention is critical, right? That helps with the, 1 in 3 people in the U.S. are now obese. It's the first time ever in the history of mankind that our children will have life expectancy less than the parents. That is unacceptable, right? So from a public health perspective, these are extremely critical issues. From a health economics perspective, in terms of cost, a lot of the debate and a lot of the discussions going into tertiary prevention. So if I have a chronic disease, if I have diabetes with complications, how do I make sure that I'm taking the appropriate preventative care in my disease so that the disease doesn't progress, right? If I have multiple myeloma, a disease that Rich's company works with, is a chronic disease. It can be controlled. People don't have to die of it. But if appropriate prevention and treatment is instituted. So the debate's actually going from primary to secondary and now to tertiary, and it is the tertiary prevention that truly helps to reduce health costs. So, as a physician and someone in public policy, I mean, I guess those are my perspectives.
I would throw in that you're seeing employers taking the lead role in trying to address this, right? Because you talk to most employers and they say, what's the greatest challenge you have in running your business? Way up there is going to be their healthcare costs. So you're seeing employers, and these are involved wellness programs and taking baseline measurements and trying to incent folks to do the right thing for employees is a fairly new strategy that employers are taking. One of the challenges is that works for a larger size employer. So if you're an employer with 3,000 employees, to the extent that you bend the cost curve, that's your money, right? For a small employer, Mike's Bike Shop with 3 employees, the wellness, because the risk is socialized throughout the entire small employer marketplace or the individual marketplace, you don't see the return on investment as clearly as you would if you're a large employer. A lot of folks are employed by small employers. So while employers are taking the lead in these things, it's still a challenge because of how the reimbursement or how the risk is socialized in the market. I would also say that I think that a lot of these employer strategies, they're not all created equal. So some of these these models, you spend $1 and it turns out you don't get great outcomes from it, and then other models really do work. So I think that folks are getting smarter about what strategies work to improve health outcomes and which ones don't. So it's I think you're going to see more and more of that from the employer community. Hopefully a way can be strategies can be used to try to get use other populations too outside of the employer context.
A lot of thought as well. So prevention and management of chronic disease, again, is one of these areas that solves the fundamental problem of healthcare. There's no amount of reducing coverage, reducing what is covered for people who have coverage, and reducing provider reimbursement that can ever meet that unsustainable healthcare. Although, of course, it's flattening now in the last few years. But the only way to address the long-term sustainability trends is by attacking the drivers of it. And if I recall the numbers right, 1% of patients in the United States account for 20% of the cost, and 5%, close to half. And the number of those are multiple chronic conditions, and the prevention and better management of those patients is a solution that not only results in better health, better economic productivity, but addressing that cost.
Here's an interesting statistic that 27% of Medicare patients are diabetics. 50%, an additional 50% over that 27% are pre-diabetics. So one of the ways you can prevent, real costs from occurring is to deal with your pre-diabetics. Increasingly, that's also in the non-elderly population.
This is somewhat facetious, and then I want to go to more seriously. So do you all think that Mayor Bloomberg is right in what he's doing? With like the 16-ounce sodas from a governmental direction?
Again, I can tell you as a physician, I think he's right. I mean, I think, when you deal with, the issue of overweight and obesity, it is our social responsibility to make sure that we have programs and systems that facilitate and assist people in terms of healthy, behavioral lifestyle choices. I know that if I have a patient who is obese or is having a problem with weight management, and you give that patient a plate full of, red meat and high cholesterol diet, high fat diet, it's difficult to say no, right? And so from a physician perspective, knowing the kinds of challenges patients have when they're trying and they're struggling with healthy lifestyle, compliance, I think we as a society need to help them get to that point. As an individual, as a person, I think one should be free to choose what he or she wants to do and live the life that they choose to do. So it depends on what perspective you're asking for, but from a public health perspective, I think he's doing it right.
As a physician, I mean, in terms of trying to induce patient compliance, one thing it may take is more time, which, given the reimbursement system, is kind of paradoxical.
Yeah, and one of the things that I've enjoyed doing over the past few months is actually going around the country and seeing some of the best practices. And there's a very big model that's just evolved. It's called the care model. And I'm not sure if you're familiar with that, but it's a WellPoint model. And WellPoint is the largest insurer in the country. And they have these specific medical homes that are led by nurse practitioners and ancillary healthcare providers, where all the patients do is come in and get preventative care, whether it's primary, secondary, or tertiary prevention. So if they need a foot exam, if they need behavioral health support, if they need education, if they need to be on a telemonitoring device, if they need access to a specialist, all that coordination is done in that facility. If they need transportation, the physician takes care of truly the clinical conditions in terms of managing the disease. So to your point, models are evolving where we're dealing with looking at innovative ways of getting to a solution and creating new delivery elements in our healthcare system. So you're right, it's such a huge need that WellPoint has invested and bought these practices. Those are, again, care more practices, because they feel that this is an investment. And in fact, when the physicians refer to these care more clinics, it's on competition. And the more they refer to care more clinics, the more they get bonus payments, because then they meet their quality measures. So things like that are evolving as we speak. Yes.
Okay. I have a second question, and this is a general question for the panel. It's the issue of waste that you touched on. In terms of, the one area of waste that the unnecessary tests and all of that being done, is anyone looking at the issue of tort reform and how that might affect that aspect of waste? And then the second aspect of waste.
Richard, I have a story to tell about this from our old days, right?
Okay. And then the
forgot his old days already.
No, I'd like to hear that. The second area of waste is the administrative waste in terms of things like prior authorization. Is anybody looking at the waste involved of the cost of things where a physician or a member of the staff has to call an untrained person under an insurance company to get approval of continuing the medication that a person is already maintained on and doing well on, or appealing to get a medication approved that now has been discounted because it's not on the list of approved medications by a given company, even though the person doesn't do as well on the medication that you want to transfer to her. And that kind of waste, that administrative waste. Is anybody looking at either of those areas of waste?
Yeah, so again, I think Ward mentioned this, or Joe did, maybe Joe, about the fact that the IOM came out with a report last year that said $750 billion, or a third of healthcare expenditure, is actually going into waste. So it's not improving healthcare. So to your point, you're absolutely right in terms of the opportunities to make the system more efficient and effective. So as our healthcare payment models are evolving and reforming, the goal is to take the whole administrative piece out of it and let the physicians be in charge of making sure that they understand what the patient needs at what point of care. I was talking to one of the largest health plan CEO a few months ago, and he was telling me that they're preparing to not be in the business of healthcare from a risk perspective, so they don't want to take risk anymore, but really